long day for all of you. Thank you for joining in. I just wanted to know the background of our participants, please. I mean, how they have had 6 sessions so far.
So far, they have
Okay.
covered the interactions, pain, communications as well.
Okay. And
So,
can you also please, with a show of hands, be able to tell me what is the exposure that you'll have had to palliative care? Accordingly, we can, have the talk because I really like the talks to be interactive because I should end up learning from you so that it's both ways. Make it more as interactive as possible to make it interesting. So, how many of you, with a show of hands, have had an exposure to palliative care, or is it the first time your exposure? What is the background of our participants? Nobody has had an exposure to palliative care? Yes, no,
We have
maybe.
started practicing palliative care in geriatric patients, so advanced stage or terminally ill patients.
Okay,
We don't have a palliative care unit, but I have attended 2 programs and I'm trying to read from the textbook
right.
and applying the principles.
Okay, so few of you have had the experience, which is good. Thank you for sharing that, sir. And I was introduced, I am a pulmonologist, and I have trained in Mumbai for. I mean, I've stayed and trained in Mumbai all my life. I've just moved to Chennai about a year ago. And my basic training is, of course, in pulmonology. But about 10 years ago, I kind of shifted gears and trained myself both in Calicut and in Cardiff for for palliative medicine. My focus, therefore, is on non-oncology palliative medicine. And the biggest thing that I want to really focus on and bring your attention to is that palliative care is for all and all for palliative care, because the most important thing, take home message, is that irrespective of the diagnosis and the prognosis, our patients end up suffering, whether it's acute conditions or chronic conditions. There is a lot of suffering. Of course, chronic conditions, the duration is longer, which means the suffering is much more longer. So, without wasting much more time, and there's also a huge topic, which is respiratory palliative and delirium. So, in the process, I think delirium is going to get a bit, it'll be quick and not so elaborate. I'm happy to consider taking an, question answer session or sharing my email in case you all have any questions about delirium. Is okay. So we'll start with respiratory palliative. I hope all of you can see the slide on your computers. The focus is going to be respiratory palliative care. So before we start the discussion, I really want to ask all of you. You all have obviously collectively been doctors for way more longer than I have. Of all the conditions that you all see in this world, how many of it are you actually able to cure? As doctors, how many of us are actually able to cure conditions? Yes.
Ma'am, only infectious diseases.
So, very rightfully, mostly infectious diseases. Having said that, so 1/3 of the conditions, be it neurology, gastroenterology, hepatology, renal disease, lung disease, heart disease, we are probably able to cure all the itis. So, pharyngitis, laryngitis, cholecystitis, appendicitis, meningitis, pericarditis, all the infective diseases, we are able to cure patients and return to normal life. 1/3 of the patients we control. Which are the controllable diseases? Anybody can either chat or put it in the chat box, or you can uh, unmute and talk. Which are the conditions we control in our entire medical spectrum? I can give you a suggestion. Yeah, somebody's put on the chat box, so thank you for that. Yes, so lifestyle diseases, which is hypertension. Thank you, Pavitra. And thank you, Ramesh. Diabetes, the dyslipidemia, ischemic heart, COPD, asthma are all the things we control, right? And 1/3 of the conditions are incurable. So, which are the incurable conditions that you can think of? Start from the head to the toe, which are incurable conditions.
Mostly degenerative conditions with
So
aging.
neurodegenerative,
Degenerative.
Parkinson's, dementia, motor neuron disease, maybe cerebrovascular accident, which is really bad, or subarachnoid hemorrhage. Yeah, these are incurable. Then you come down, chronic obstructive lung disease, advanced interstitial lung disease, ischemic heart disease in an elderly with an ejection fraction of 10 or 15%. So congestive cardiac failures or very bad valvular disease in a patient who cannot be operated, cirrhosis of the liver where there is no transplant, advanced stage CKD where there is no renal transplant, correct? And of course, incurable cancers. Lots of times we are lucky these days that there are some cancers which really do well. Yes, so there are a lot of cancers which do not do well, right? So incurable is one third. So the question comes that why are we so proud of becoming doctors? We do not manage to cure two-thirds of our patients, right? To one third is controlled, one third is incurable. So we gloat on the fact that we are able to cure one third of the patients. So the reason I'm highlighting this is to bring back to the point that two-thirds of our patients really require handholding throughout their journey of having the illness. We are only doing stopgap arrangement. We treat the sugar, we treat the infection, we treat this, we treat that. We really do not manage to get rid of their diabetes or blood pressure or ischemic heart or dyslipidemia. So that brings us to the focus of the number of Indians today who are affected with what we call as non-communicable diseases, or I like to call it as non-cancer diseases, because we do add 1 million cancer population per year to our full medical list of diseases every year in India. But if you see, cancer still comes at the bottom. All the reasons that Indians are dying of is still tuberculosis, the dangerous forms of tuberculosis, respiratory conditions, diarrhea, and other common infectious disease, diabetes, heart disease, and stroke. So, if you see the number of Indians suffering from non communicable diseases and the number of Indians dying from non communicable diseases are way more than that of cancer. I'm not denying that cancer is an important feature. We are adding a lot of malignancies every year in our list, but we are the diabetic capital of the world, and diabetes has its own complications. So please remember, the percentage of population affected with non-communicable diseases in India are on the rise. Young people are being affected by it, and almost always, if you see, 44 every fourth or fifth Indian has one or two non-communicable diseases. So please remember, it's very important. We cannot afford to forget the percentage of population affected by these, and these are not curable. These are only controllable, and these can only need hand holding, which is nothing else but palliative care. Focusing on respiratory conditions, COPD, tuberculosis, interstitial lung disease are all on the rise. Unfortunately, tuberculosis being an infectious disease is still so badly managed that we have managed to create drug resistant, multi drug resistant, total drug resistant, and extremely drug resistant tuberculosis. So, we are a nation that is very high ranking with MDR TB, and yes, we have managed to reduce the incidence now with the new regimen, which is the bedaquiline regimen, but still we are still losing young patients between the productive age group of 15 to 50 every day due to these dangerous forms of tuberculosis. COPD, of course, it's not just environmental pollution, it's also domestic air pollution along with cigarette smoking, which is causing the rise in the incidence of COPD. And more, we are seeing the rise of interstitial lung disease right from the age group of 20 to the elderly age group of 60 to 70. So there's a huge rise in all these conditions, and therefore our focus needs to be on how to improve these patients' quality of life, given the fact that we may not be able to cure them of their condition, right? So why should we talk of palliative care in respiratory medicine? Because palliative care focuses on health related suffering of the patients and the caregivers. And the point, what is important is that the curative aspect that pulmonologists offer and what palliative care physicians offer should actually work in hand to hand and parallelly, because These conditions, advanced COPD, advanced interstitial lung disease, affects the consequence of the patient's quality of life. Patients die in isolation. They have problems in activities of daily living. They become more and more dependent on their professional and domestic caregivers. So there is a lot of struggling. There's a lot of effect of quality of life, and therefore it's very important to talk about it. So we will see how it can be done. How many of you have seen this graph? No? Okay. So if you divide the way the population of the world dies, it can be largely fit into these four graphs, which is graph A, where there is sudden death, where people enjoy a great quality of life, and then suddenly it could be accident, it could be a national catastrophe, it could be just a cardiac event. So these patients die suddenly, where they've been enjoying good quality of life and then they suddenly die. Now, can any of you guess how many people in the world die suddenly? Any guesses? Anything in the chat box? So only less than 10% of people die suddenly. Less than one. Okay, somebody is even more pessimistic than me. 10% of the population dies suddenly, and unfortunately, most of the sudden deaths happen under the age of 50. Like you have seen all those people from the TV, people in the movies, they're exercising 1 minute, gone the next. So majority of the deaths happen under the age of 50 if it's a sudden death. What does that mean? That means that the rest of the 90% of the world will die a death which is prolonged bedridden. Either it's 1 day, 1 hour, 1 week, 1 month, 1 year, 10 years. We are not aware. But what we need to realize that only less than 10% die suddenly, which means 90% require handholding, supportive care, comfort care, which is nothing but palliative care, which has to go hand in hand with the curative care. Coming to graph B, if I hope everybody can see it, this is a typical graph or trajectory in a cancer patient where the patient enjoys good quality life and then slowly with the advancing of disease or with comorbidities or metastasis, the patient is on the slippery slope to death. And this is where the active integration of palliative care helps patient and caregivers prepare for an eventuality, plan for the future, and therefore this is where the cancer palliative care interaction happens. And historically, palliative care was started by this famous lady called Dame Cicely Saunders, who started a hospice in London looking after patients with advanced cancer and who were dying. So even now, people believe that palliative care is meant for only those who are actively dying and those who are actively dying of cancer, both of which is not true because there is suffering across the board, irrespective of the diagnosis or the prognosis. So that brings us to graph C, which I have enlarged on the other side, the right hand side, which is typical of an organ failure, which could be heart, lung, liver, brain, anything. Now, what is interesting about this graph is that these people enjoy a good quality life till the point they are diagnosed, which could be 60 or 65. If you take dementia or if you take maybe even COPD. Now, they lead a prolonged period of time with high symptom burden. How long do patients with COPD live? Easily 10 to 12 years. Patients with dementia, again, easily 8 to 10 years. So, what we need to focus is non communicable diseases. Our patients live a prolonged period of time with high symptom burden, which means a lot of it from the time of diagnosis to death is constantly hospital interaction, doctor interaction, OPD, ICU, emergencies, all this keeps happening in their lives. Second thing, which is very important, is that non communicable diseases are not perceived as life limiting. What does that mean? Suppose I diagnose a patient to have lung cancer. What is the first thing that comes into the patient's minds? Anybody? What is the first thought if anybody gets diagnosed to have CA? You tell the patient you have cancer of so and so. What is the immediate reaction that is likely to get from the patient?
How long will I live?
So the immediate reaction is, okay, how much time do I have? Suppose I diagnose a patient to have COPD or CKD or cirrhosis. What is the first question that the patient will think? Will it be death or will it be doctor साहब आप तो treat करोगे? There is treatment. So, the concept of non-cancer diagnosis is not put as life limiting. Secondly, when patients don't think it as life limiting, doctors also are happy. You didn't ask, I'm not telling you about it. So I will wait, I will keep treating. And the third most important thing is the trajectory of a non-communicable disease. Every time there is a dip, the patient gets admitted in the ICU or the hospital. We as hospital doctors see this patient only in this acute emergency. When this patient goes home, every time you see there is a dip in the quality of life, in his functionality, the more and more dependent, right? So he never returns to original quality of life. Secondly, we never know how this patient is being treated at home. Is he self caring? Is he able to dress himself? Is he able to shower? Is he able to eat? Is he able to walk? We are not bothered about it. How are we trained? Look at him when he comes to the hospital only. What happens in the house is really not trained for us. And also, if you see research, okay, two diabetic patients or two dementia patients, they never have the same trajectory. But if you see, the research has been done on, say, stage 1, 5-year survival rate, breast cancer. You can predict the outcome in cancer mortality. In a non-communicable disease, the prediction becomes difficult because it is an unpredictable course and it is a roller coaster ride. So no two COPDs have the same trajectory, no two diabetics have the same trajectory, no two ischemic heart disease have the same trajectory. So doctors are not able to prognosticate. When you're not able to prognosticate, you then keep trying, you keep giving hope, you keep admitting the patient to ICU instead of sitting down with the family, having a discussion, saying this is not working, this is not looking good, we really need to opt for another way of treating this patient. So this is what typically happens in an organ failure. And the last one to mention here, of course, is the frailty, where we see lots of Indians now who are 80 plus or 90 plus. Like I always make this comment, when I did my MBBS, I rarely saw a 90-year-old. Now, every household has one 90-year-old. So we really need to prepare ourselves for this grey nation boom that we are going to have in 30 years, where the number of 80-year-olds will increase by 700% and the number of 60-year-olds will increase by 300%. So we really need to have a plan of what we are going to do and how we are going to manage all these elderly. Okay. So this brings to our focus of the organ failure, and we're going to talk on this very interesting paper which was published in an Italian medical journal, where they compare the any chronic illness, put it as dementia, COPD, or interstitial lung, CCF, as falling off a chronic disease skyscraper. Okay, the manner in which you land depends on the way you fall. What am I trying to say? That if the fall is punctuated with appropriate, sensitive, unhurried conversations, and the patient and the family are time to time told about the trajectory, what to expect of the disease, they're better prepared. What happens today is we wait till the patient reaches the first floor and say, sorry, but everything, nothing is going to work. We cannot do anything to save the patient. The disease has really become very bad. So, my question to you is, as a neurologist or a pulmonologist or a cardiologist, who is more aware of the trajectory of dementia, COPD, and CCF more than the patient? Is it the doctor or is it the patient? Who has seen more patients of each of these conditions in their specialty? Isn't it the doctor? It
Yes,
is,
ma'am.
right? So, whose onus is it to take that responsibility and explain to the patient and caregivers? Like I said before, patients don't ask, doctors feel very happy. You didn't ask, I'm not telling you. But please remember, it is our onus to foresee and foretell what is coming in a dementia, what is coming in a COPD, so that patients and caregivers are better prepared. They don't do Google search and come and irritate you with 25 questions which are unnecessary. And at the same time, you do not subject them to unnecessary, futile medical procedures at the end of life. So it is very important for us to foresee and foretell, because now we get referrals so late that the dementia person doesn't even know who he is, or doesn't even know where to sign or what his signature is, or the COPD patient is so breathless or unconscious because of his carbon dioxide that he's not even able to say, I want a ventilator or I don't want a ventilator. So please remember, in chronic conditions, like in non-cancer conditions, there is time. We need to use that time by seeing to it that we talk to patients. Communication is so important that we have timely conversations, difficult dialogues with our patients and caregivers so that they are better prepared. This is very, very important, because really the responsibility lies on us. And this is exactly what we want to do in palliative care, is to integrate palliative care as early as possible in any condition, because palliative care is a need-based science. Anybody who's not coping well, or anybody who's struggling with the diagnosis or struggling with the treatment, needs the helping hand of a palliative care team. And if not at the time of diagnosis, we really need to introduce palliative care as a part of the team member of the curative care. So every specialty needs a palliative care integration. As the curative falls, the palliative care team should take off, help the patient, help the caregivers, not just during the treatment, but also at the stage of active dying, and followed by that in the stage of bereavement. Because the void that is left after looking after a parent or a grandparent with 10 years of dementia or 10 years of COPD, it can be quite devastating for caregivers. So palliative care not only looks after the patient while going through curative treatment, but also handholds during end of life and also during the bereavement. So it's very, very important to integrate palliative care and not abandon your patient saying, now I cannot do anything, now go to palliative care. But the palliative care team should be a part of the treating team, so that when there is a dip, or in anything, physically, emotionally, psychologically, socially, when the patient is not coping, when the patient's quality of life is affected, that is the time to integrate palliative care. So, very often, this biggest barrier in the minds of consultants is, when should I be referring to palliative care? If I send the patients too early to palliative care, they lose hope. So, is that right? So, there was a research done in UK which is called as a surprise question. And what was that surprise question? As general practitioners, as private practitioners, as hospital consultants, if you have a patient walking into your OPD and you think in your own mind, will I be surprised if this patient was not alive in the next 1 year? If the answer to this question is no, that is the time to integrate palliative care or send the patient for proactive palliative care. So, what is the question? In your mind, you ask yourself, will I be surprised if this patient was not alive in the next 1 year? Okay. So, simple indicators for you are, in COPD, for example, there is a clear cut indicators. If the patient satisfies any two of these indicators, which means if either the patient is elderly with uncontrolled comorbidities, recurrent hospital admissions, one ICU admissions, or a fall in lung function, or 24/7 oxygen. So if the patient has had any two of this, research has shown the probability of this patient being alive and well in the next 1 year is almost zero. Therefore, you get that 1 year as a palliative care physician to understand the patient, to interact with the family members, to explain the trajectory, to tell them what all may be in store for them, how they would like to be treated, document it, and now we have advanced medical directive in this country. So we need to start encouraging those patients who are doing poorly, who are in their advanced stage of condition diseases, to clearly make up their mind as to how they would like to be treated. So I have given you example of COPD. The these two papers, which is the Blue Maple and the Gold Standard Framework, both of which I will request Pallium India to share with all the participants clearly documents indications to refer patients in every chronic condition: Parkinson's, motor neuron, dementia, CKD, cirrhosis, CCF. So, if you follow this, you immediately can separate those patients who are going to fall into this little fragile category of those who may not live beyond 1 year. Any thoughts or any points you all want to share, or are you all with me up till now? Anybody? Continue?
Yes, ma'am.
Yeah? I can see that only Dr. Anil Kapoor is and Dr.
Yes,
Pavit
ma'am.
is awake. Rest everybody? Okay. So please remember, I will tell Pallium India to share these documents with you. Each of them gives you clear indications of when we should be referring these patients to or integrating palliative care. Okay, because research has been done in patients with cancer and without cancer, even in the West. And unfortunately, even in the West, of all the patients admitted to the ICU, palliative care was given only to less than 2% of patients with non-oncology diagnosis. So more than 80% of patients with cancer patients got palliative care. The problem is those patients who did not get palliative care integration in a non-oncology setting unfortunately ended up with more aggressive interventions, less distressing symptoms documented. They underwent more CPR and therefore they died a miserable death. And in India today, we are ranking amongst the 59 worst countries to die in a quality of death index. Unfortunately, in India, across the socio-economic status, whether you're poor, you die of ignorance, or sorry, basically in if you're in when you're in the lower socio-economic society, you really die of negligence. Middle class dies of ignorance, and the rich die on a ventilator. Across the socio-economic, there is agony, there is suffering, there is a lot of what you say lack of trust to healthcare professionals. So it's very, very important to focus not only on the way the people live quality of life, but it should be quality of death. So they need to live well till they die, and they also need to die with less suffering, less interventions, especially when it is proved to be futile. And even if we admitted patients of COPD, we realize that more than 50% of patients come back, keep getting admitted, and only 25% actually are alive and well with a good quality of life. So please remember, we only focus on our duty, we only focus on that particular admission. We really need to look at the larger picture, what the patient wants, what the family understands, and we need to tailor our treatment depending on what that is, because that is the reason why the trust and faith in doctors are at all time low, because everybody is here to push their agenda. We cannot do it my way or the highway, because we are not the ones going on the ventilator. It is the patient, and the suffering is immense for the caregivers. So please remember, even if you aggressively treat COPDs, you see close to 70 to 75% of patients are dead in 3 to 5 years. But we actually need to know whether the time they live, the last few years of life, whether it's in and out of hospitals or whether they're doing what they want to do, they're meeting people where they want to meet, what are we actually achieving by prolonging poor quality life? I am not saying we play God and end life, no, but we also need to know where to wear the palliative care hat, give them the comfort so that they can lead a good life and not just in and out of hospitals. So it's very, very important to understand that our patients who have a physical decline due to being respiratory cripples parallelly also have mental health decline. It is very, very important for us as doctors to be able to elicit this decline in our patients. We are so focused in a respiratory patient to only ask about cough, breathlessness, able to walk, going to sleep, etc., etc. We never ask patients and caregivers whether they are coping with the diagnosis, whether every day to day looking after these patients, taking them to the toilet, assisting them in the shower, giving them a bath. It's so much happening in the house. I'm sure by now a lot of you have been caregivers to your loved ones at home. It is not easy, and they really need the support of a professional team. So we actually need to start asking patients who are respiratory breathless, chronically breathless, to actually ask them how they are coping. Are they anxious? Are they, panicky? What are they worried about? Are they, so a lot of things we need to focus in asking questions, so that we actually open our way we look at patients. When we think of dementia, we only think of neurology. We forget the human being. When we think of the heart, we forget who the person is. It's very, very important to see the holistic picture and have a holistic view. And that exactly is palliative care. It's not just physical symptoms, emotional, psychological, social, financial, and spiritual. So we have to see the person as a whole. Okay. So this is also important to include caregivers. How many of you acknowledge the hard work done by caregivers in a chronically ill patient when they come to your clinic? By asking the caregivers, have you been on holiday? Are you getting enough sleep? When is the last time you went out to watch a movie? Or when is the last time you went out for a pedicure? It's not that you're going to be able to fill in that gap and help the caregiver, but the fact that you acknowledge their duty of how much they contribute, because without these caregivers, for all you know, a lot of our patients only might not be alive. So please acknowledge to the caregivers about how much they do in looking after these patients, and it's important to involve them also in the explanation of what is happening to the patient, because they are going to be hands on with the patient. So in case of breathlessness, we need to tell them how to manage an acute event on a chronic, how to manage the anxiety and panic, support them, give them some advice as to what to expect in the future and what to do in an emergency. So, what we do in respiratory palliative care, please remember the patient is the center of our focus. So, I've taken the example of interstitial lung disease. Like I finished talking about COPD. Interstitial lung disease is a condition which has really no cure, especially the fibrotic variety, especially the idiopathic pulmonary fibrosis. So, it's important for us that when you diagnose it, you really need to support the patient with not just effective drug modulation, effective treatments for symptoms, and we need to educate the patient and the caregiver about future, plan for the future, prepare advanced medical directives, goals of care. So this is all that we do. So tomorrow, when I get referred a patient of interstitial lung disease, I first start by asking what the patient understands about the disease, explain to him, if he's given me permission, about the disease itself, tell them it is incurable, it is progressive, and slowly, as more and more of the lung gets affected, he is going to get more and more dependent. Try and help him with vaccinations, with pulmonary rehabilitation, chest physiotherapy, long-term oxygen. Find out what his joys are, what he would like to do, and try and help him plan this with a multidisciplinary approach. So it's very important that palliative care is not just about doctors, but it's about nurses, it's about physiotherapists, counselors, social workers, volunteers. So they are all make a safety net for our patients, and they can therefore approach any member of the team depending on what their needs are. So if you see the needs of a patient with interstitial lung disease, it is huge. It starts with information. Why did I get this disease? Along with the disease modifying agents, awareness, the complications of getting interstitial lung disease, psychological support, end of life care, and the fact that they all really need to also live well with ILD and also die well without unnecessary futile prolonging of life. Okay, so if you see this is a beautiful diagram of ABCDE of how you can integrate palliative care in the management of ILD. It's a bit in detail maybe for all of you, but it really gives you how you should first be assessing and how you should share information with patient and caregivers, back them with information, with support groups, with rehabilitation, with vaccination, give them the treatment for all the distressing symptoms, starting with breathlessness, cough, fatigue, anxiety, depression, and control the comorbidities. Start the disease modifying agents like pirfenidone and nintedanib. Some cases now lung transplant. And most important, we have to discuss with the patient about end of life care and about what they would like to do for us, for them, from us, how to support them, what to prepare, where they would like to die, etc., with the end of life care discussion. So, this is in gist how we actually integrate palliative care with interstitial lung disease. The focus is the patient's quality of life, and we actually give them all these domains of care. Okay. Now, come to a very important point of evaluation of breathlessness, because you are going to see a patient who is going to be chronically breathless. Now, there is a different, I think you'll have already had the session on pain, and like chronic pain, most of our patients with advanced respiratory condition or advanced cardiac condition end up in a situation called as chronic breathlessness syndrome, wherein despite the patient being on optimum treatment for their pathophysiology, they end up suffering with poor quality life, or the breathlessness comes in the way of their normal day-to-day life by affecting their psychosocial emotional health. So there is a concept of chronic breathlessness syndrome. Okay, when you have a patient who is chronically breathless, I know you all will order all these tests, that is not a problem at all, but I feel that 2D echo and lung function test and arterial blood gas is very, very crucial to actually tell you the significance of or the advancement of the disease. How bad is the illness? You come to know with a 2D echo because patients get cor pulmonale. Lung function shows you the values of how poor the lung capacity is and the diffusion capacity of lung for carbon monoxide, especially those in interstitial lung disease. So please remember to include these three things amongst other things. But what do we forget to ask these patients of chronic breathlessness? Anybody? What are the real issues of these patients? What really matters to the patient?
Is he able to do routine activity or walk to toilet?
Okay. So independence.
Sleep.
Okay. Anybody else? Dr. Kapoor has given you the hint. What else? Sleep, yes, Dr. Ramesh, thank you. So sleep is yes. Independence. One of the big things is independence. Then what about anxiety? How did all of us feel in COVID, locked in a room? Our patients are bedbound. Our patients are housebound. Our patients are hooked to oxygen 24/7, day after day, week after week, year after year. So there are a lot of mental health issues. So the actual issues of breathlessness is what we need to evaluate. They have limitations in activities of daily living. They're dependent. This man used to once run the house. Now he is nobody. He's in one corner of the house. He's socially isolated. So our patients with chronic respiratory diseases die a social death even before a physical one. They're not able to go out. They're not able to meet their friends. They're breathless talking on the phone. They cannot eat with the family because they cannot walk to the dining table. So there's a lot of, could be frustration, could be anger, could be depression, and also could be a constant fear of death. Every time he's doing something, oh God, I'm so breathless, am I going to die? So these are the things we need to elicit. And how do you elicit that in a history taking? How can you ask your patients? Anybody of you, you can try to tell me in the language that in the region that you all are working in. How will you elicit this history? History taking is very, very important. Yes, thank you, Dr. Vaishnavi. How will you elicit this history of anxiety, first frustration, depression, loss of role? Anybody? Yes, Dr. Sajida.
Are you able to do things? Are you able? Do you want to? Uh, Actually, I do not know, madam, how to
No,
ask
no,
like
simple
that.
question. Best way to elicit is what have you stopped doing because of your breathlessness? Or What is it that you would have liked to do if you were not so breathless? So, depending on how intelligent your patient is, what is it that you want to do and you're not able to do because of your breathlessness? Or what is it that you have stopped doing? And that opens the Pandora's box. Oh, I cannot even go to the toilet on my own. I cannot dress on my own. I cannot play with my grandchild. I cannot go to the garden. So many things will come. And then you can start, do you remain anxious? Your mood remains low? Do you feel like crying? Do you meet people? So all that can build on this one simple question. What have you stopped doing because of your breathlessness? And therefore, history taking is very important. How do we ask questions? Closed ended. Is your breathlessness better? Are you feeling breathless? So we give the patient the chance only to say yes or no. And most patients do not want to displease their doctors. So they will say yes, or they will say exactly the same answer that the doctor should not get irritated with. Correct? So please remember, the way you ask a question to your patient also elicits the right amount of responses. So please remember, your few select patients will be this vulnerable. Not all your patients will fit into the criteria of integrating to palliative care. Those few you should handle with care. Those few you should really remember when to integrate to palliative care and get the most so that you focus on their quality of life. Because quantity of life is something we really cannot change. We cannot change the COPD, we cannot change the ILD, we cannot change the disease. But what is in our control is what we should be able to do. And that is exactly explained in this breathing, thinking, functioning model. So I want you all to imagine a patient of COPD, advanced disease, or interstitial lung on 24/7 oxygen, right? This patient is sitting in a room on the bed with the oxygen, and he's breathing at the rate of 30 or 32 breaths per minute. Okay. The only thing that is active is what in his body? Yes, anybody?
Minds.
Exactly. So the only thing that is active in this person is the mind. So the mind is racing. Anxiety, panic, depression, fear of death. Oh God, all the thoughts of what have become, I have a burden. So many things are happening. So he's actively thinking. Because he's so breathless and because he's so anxious, what does he decide to do? Hold to the bed or hold to the chair and do not get up at all. Why? I walk to the toilet. I am so breathless, I'm going to die. So in the process, what does he become progressively? If you have a person sitting on a chair for 2 weeks, 2 months,
Anxious, obese,
obese, more than obese, if you don't use your muscles, you
wasted.
lose your muscles. Correct? If you don't use your muscles, you lose your muscles. And what is wasting in medical terms? It is called as
Sarcopenia.
deconditioning. Correct?
Yes.
So that means what? Suppose tomorrow you have a fracture of the leg, you're in the bed for 6 weeks, and on the seventh week you get up. How do you feel? Wibbly wobbly, ready to fall, even though your heart, lung, everything is normal, right? Our patients who do not move at all are deconditioned. So they are then caught in this vicious cycle, which is called the breathing, thinking, functioning model. Very breathless, very anxious, very immobile. So deconditioning. Again, what happens? This deconditioned human being walks 2 steps, again he'll get very breathless. So he's caught in this vicious cycle. This is where palliative care integration helps to break this vicious cycle. How? Pulmonologists treat the breathing by giving all the medications, right? Bronchodilators, steroids, antibiotics, antifibrotics, depending on what this patient needs. Counselors, as a part of the multidisciplinary team, address the patient's anxiety, find out what he's worried about, what is his future like, what are his financial problems, try to address all that, or at least acknowledge the distress. The minute you acknowledge that, yes, I can see there are lots of things that you need to worry about, at least we understand his problems. Physiotherapists are the ones who help the patient return to functionality. So, with the underlying chest problem, with the underlying lung function, this patient is encouraged to do small activities so that he can do going to the toilet, going to the dining table with less effort. It's not that he's going to be dramatically changed. So I can ask you a question another way. Tomorrow, if some of you decide to do 20, 40 kilometer marathon, what will you first do?
Warm up.
Start with
No,
smaller
suppose
distance.
So you start training, correct? You first go to the gym, you build muscles, and you start running 1 kilometer. You can't get up and start running 40 kilometers tomorrow. Even if you're a normal human being, you have to mentally and physically train yourself. So we need chest physiotherapists to mentally and physically train our patients to be able to go to the toilet. For them, that is their marathon. To be able to take a shower, to be able to go to the dining table, to be able to talk on the phone, because they're so badly crippled with their breathlessness, they cannot even take a step. So this integration with physiotherapists, counselors, social workers, nurses, palliative care physicians, the specialist pulmonologist, forming the team of the palliative care helps this patient to do his day-to-day activity with less and less effort. So at least he's able to do that. So the patients feel really good if they say, today I could go to the toilet on my own. So this dignity that we restore, right? The comfort that we give patients, that is what is the beauty of palliative care. So much can be done. Yes, we acknowledge that we cannot change the COPD, we cannot return the lung function, we cannot change the anatomy of the lung, we cannot even change the outcome of his disease, but we can make this journey bearable, we can make the journey memorable, we can also give the patient the dignity, respect, and comfort that every human being deserves. So please understand, all our patients of chronic breathlessness are stuck in this horrible vicious cycle, and palliative care really helps to break this vicious cycle in order to return them to good quality life. And coming to exact, this is the definition of chronic breathlessness syndrome, where patients are on optimum medications. Despite that, when they have physical limitations and life is affected adversely in a psychosocial, emotional, spiritual manner, that is the time when you have to label the patient and really integrate to palliative care. And once you have a patient of chronic breathlessness, like everything in palliative care, it's important to focus on non-pharmacological actions. It's very easy. We are all trained to dish out prescriptions immediately, but we really need to focus on non-pharmacological, and they do go a long way in managing this chronic breathlessness. So positioning of the patient, loose clothes, relaxation breathing. There are cognitive behavioral therapies that you can do for breathing, the box breathing, or the patients can imagine some nice place they want to be, and that can calm them. Pet therapy, music therapy, also fan therapy. How many of you have heard of the fan therapy for breathlessness? So a simple technique like a handheld battery operated fan, if you blow it on the patient's face, there is enough evidence to suggest that the patient's respiratory rate drops. By sequential MRI imaging, they have seen that the brainstem becomes calmer and calmer and stops sending signals to the lung, and the respiratory rate falls. So the first point should be the battery operated fan and not the casualty call or the ambulance call to rush these patients, especially in a chronic disease. And for patients who are acutely ill, I'm not saying this. For chronic breathlessness syndrome, where patient is a known case of an advanced respiratory disease, the patient is constantly breathless and becomes even more breathless, these patients, you must try the non-pharmacological, very, very important. Because amongst the pharmacological things that we do have is all that you know, but most important is oxygen as well as morphine. A word of caution about oxygen: please do not overuse and abuse oxygen. All breathless patients are not hypoxemic. Breathlessness can be due to variety of reasons: pain, acute retention of urine, some bad news, anxiety. All this can cause breathlessness. So all patients of breathlessness are not hypoxemic. So like in the pandemic, we overuse and abused oxygen. Please use oxygen only if the saturation is below 88. Because if you remember physiology, oxygen dissociation curve, only saturation below 88, there's a sharp drop of the arterial oxygen partial pressure. So if the oxygen saturation is above 88, there is no need for oxygen. So please do not abuse oxygen, because oxygen also is a drug. Excess oxygen causes the release of nascent free oxygen radicals, and that can affect the lung more. So use only if the saturation is below 88. Morphine is a drug I would like to talk about. Current evidence has a mixed bag of evidence. About whether it benefits patients with breathlessness is a question mark. But you can select your patients with chronic breathlessness, try morphine, closely review, and if it doesn't help, you can clearly stop the morphine. But if you see there is some benefit and some improvement of quality of life, then you give those patients who are terminally ill some relief and respite by starting or opioids. So the same opioid that you use for pain can be used in morphine with the breathlessness, and without stopping any of the other medications for their underlying pathophysiology. So according to the COPD, we have a step ladder treatment for COPD and asthma. So along with the other increasing other medications like short acting bronchodilators, long acting bronchodilators, your long acting muscarinic receptors, your oral bronchodilators, etc., physiotherapy, slowly you can introduce the opioids. And how do we introduce opioids? Please remember, the stepwise approach should be: first, always try non-pharmacological across mild, moderate, severe. Then consider SOS opioids and see if the patient's breathlessness is relieved. Then you can start regular opioids. And then, of course, in actively dying patients, we give something called as palliative sedation. So typically when we start with opioids, what we actually do is, sorry, 1 minute. We start a low dose of opioids. So in India, we get immediate release only, at least in Bombay, where I used to practice. So we start with a 2.5 milligram immediate release opioid of a 10 milligram tablet. We divide into 1/4, give morning and evening, review the patient for 3 days. If the patient is better, we slowly increase the dose. We never go more than 20 to 25 in 24 hours. So there is a ceiling dose for opioids in patients with breathlessness. There is no ceiling dose for opioids in patients with pain. We do not go more than 20 to 25 for the obvious reason that it can cause central nervous system depression. So we never go. But you please need to review whether patients are improving. And second most important thing, you must prescribe a laxative. Without laxatives, the opioids can be really disastrous. Why? Because opioid acts by stunning the GI and there is constipation. It is a 100% side effect of opioids. And if you have a breathless patient who is constipated, that is a recipe for disaster. So you must change their diet and you have to give laxatives with opioids. So always start low, go slow, increase the frequency, first 12 hourly, 8 hourly, 6 hourly, and 4 hourly. Never exceed more than 20 to 25 in 24 hours. If patient is not responding, do not give, go back to evaluate what is the reason, some other cause for breathlessness, anything else, and then go back to the drawing board. Okay. And it has been proven that if you integrate palliative care, what they call as breathlessness support service, so you actually take the patient, do the physiotherapy, involve the counselor, look after the caregivers, these patients not only true, but they at least lived very well and they at least lived the way they wanted to, which is very, very important for every human being, right? So oxygen, I already told you, it is not related to hypoxemia. And why is it important to recognize? Because our patients with interstitial lung disease and COPD have worse symptoms at end of life compared to lung cancer, if not more, if not the same. So if you must remember that palliative care is for all. It's irrespective of the disease. It's irrespective of the diagnosis and prognosis. It is a need-based science. Whoever is not coping, whoever you know is not going to improve, it's an incurable disease. And if they are not coping, they really need the handheld and difficult dialogues of goals of care and advanced planning, right? So morphine is a safe drug. In the doses that we spoke about, it does not cause respiratory depression. It does not worsen hypoxia. It does not worsen the carbon dioxide. In fact, how does morphine act? It acts centrally, so it reduces the work of breathing. It reduces the respiratory rate. So from 40, it becomes 30. But for that patient, it's a good, significant number. Instead of going, he goes, it's much better. So the depth of respiration, the tidal breath improves. So oxygen diffusion also improves. Always start low, go slow, and titrate very, very slowly. And please do not hesitate to stop if it's not working. But recently, there has been medication and indication that it works well for cough. So, this is how we use morphine. I will be sharing the slides. And also, it's important to get your counselor input. If there is anxiety or if there's a panic attack, you can actually combine it with medium or long acting benzodiazepine so that the anxiety part is also taken care of along with morphine. So you need to have proper evaluation. You need to have patients who are MMRC grade 4 or 5, which is breathlessness at rest, and that breathlessness, which is affecting their quality of life in a psychosocial, emotional manner, are these patients where you need to integrate palliative care, label them chronic breathlessness, and start with opioids. Okay, so it is a good drug and it is a safe drug, but you have to select your patients well. Any questions before I move on? Because I think it's already 4 o'clock. Okay. So I will just touch upon terminal breathlessness, which is very, very important because these are the patients who are actively dying. So it's the very important to talk about it because those patients who have expressed wishes of not going to ICU, not being on the ventilator, advanced COPD, advanced interstitial lung disease, unfortunately, when they don't die suddenly, they still need care. They still need to be taken care of, and you really need to keep them comfortable. That is their right and our duty. And after a proper conversation, multiple conversations, also getting the counselor's head that the patient is not frustrated and wants to give up life, we identify medical aspects of actively dying. So either the saturation is not maintained, BP is not maintained, patient is obtunded, patient has shallow breathing, or continues to have no urine output. So when this patient, we select patients properly about those who are actively dying, and we actually do administer, after proper communication and documentation, what we call as palliative sedation, where we aggressively control the symptom of breathlessness so that the patient doesn't experience like a fish out of water. So we do give 10 milligrams of morphine along with midazolam. If the patient is agitated, we add a small dose of haloperidol so that the patient transitions in sleep. The intent is not to end life. The intent is not a whopping dose of a medicine to end life. We give tiny doses over 24 hours and we give it through a syringe driver so that the patient is just comfortable for himself, comfortable for the caregivers, because it's important that the caregivers also remember the manner in which their loved one passes away. It's very, very important because that is etched in the memory of those who live on. So it's very important to discuss this, document this, get signatures, and then we initiate palliative sedation. We have done that, especially in terminal cancers, terminal COPDs, terminal ILDs, and what we really need to remember is the intent is to keep the patient comfortable. The intent is to help him transition in peace, not ending life. So that all is, and this patient would have died anyways because of his advanced disease. What we have done is kept him comfortable till death. We do not hasten death or we do not push death. That is not in our hands. What we can do is keep the patients alive. So typically, we initiate this in the last 2 or 3 days of life, and this is at that much only that the patient actually, that is how actively the patient is dying because of his disease. So we just ensure patients are comfortable. So if I have the permission, I'll just go through cough and maybe pleural effusion, and I don't know if I'll have the time for delirium. I don't want to waste everybody's time. We can probably do a short half an hour if you all have some other time to do delirium, but I'm happy to do the cough, finish the respiratory symptoms. So cough, again, very, very important. It can be very distressing to people's quality of life. And what we actually do is, though it's a protective reflex, when it's distressing and persistent, it can really complicate the patient's life and that of the others. In a plane, when you hear somebody constantly coughing, it really can get very irritating. So causes, again, you should remember, it can be anything, not just the lung. Please remember, it could be upper respiratory tract, it could be ear, reflux, cardiac, drug related, radiation related. Sometimes it can also be attention seeking in children, which we call as psychogenic cough. So it could be anything. History taking is important. And along with that, the pharmacological, non pharmacological. So in non pharmacological, if you attribute it to the GI, then you have to have lifestyle measures, early light dinner, small intermittent meals, 3 hour gap between eating and sleeping, don't sleep fully flat, sleep a little propped up. So all these lifestyle measures are important. Hot water, steaming. So all the non-pharmacological should be discussed with the patient. And of course, one of the things that has been recently published is low dose morphine for cough in patients with interstitial lung disease. So the refractory dry cough works very well in ILD cough. Morphine works very well. Other than that, you can also use benzodiazepine in cases of, psychogenic, in cases of metastatic lung cancer, especially mets to the lungs. And psychogenic needs a completely psychiatric evaluation. And of course, you should use opioids in properly documented conditions of refractory cough in an interstitial lung disease, right? So, in another important drug that has been researched for cough is gabapentin. Only used in the night because the side effect is drowsiness. It works well for people with cough. So you can use gabapentin as a treatment for refractory cough where you do not have the cause at all, right? Pleural effusion, again, it's a malignant pleural effusion, usually typically seen with recurrently filling pleural effusion, especially from cancer across the body, lung, breast, bone, etc. Please remember the way we treat pleural effusion management, it depends directly on the prognosis of the patient. If the patient has got a good prognosis, which is good functional status, we can put an indwelling pigtail catheter, or we do one-time aspiration if the patient's prognosis is less than 4 weeks, and then give them low-dose morphine so that they don't feel breathless. But everything is dependent on the patient's prognosis. If the patient has good prognosis, then we drain the fluid. We can even do something like the bleomycin or the talc pleurodesis, where we fuse the two layers of the pleura, and so there's no potential space, so that there is no accumulation of fluid. So it is important to get the advanced stage of the disease before we do any heroic treatments. Similarly, hemoptysis. Now, this is a very scary symptom for patients to experience. None of these symptoms, the hemoptysis cannot be managed at home. Patients need to be given tertiary hospital numbers where complicated procedures like bronchial artery embolization, brachytherapy, laser, cryo, etc. can be done. And patients need to be prepared that it can happen, especially if you know it's very close to an artery or there is an aneurysm in the lung. We need to educate that anything can happen, and therefore we need to see to it that these patients are reaching the hospitals at a good time so that all this can be done even in for palliative, because otherwise most patients of hemoptysis die with aspirating their own blood. So that can be quite a horrible way of dying, and it's important to educate patients before. I'll lastly touch upon other symptoms we really need to focus on in respiratory is fatigue, insomnia. Most of our patients will complain about that. Important part of these non-respiratory symptoms is to acknowledge that the patient is struggling, support the caregivers, give them ideas of how they can be, managed with physiotherapy, with dietitian, and even with counseling. So I will just like to touch upon the pandemic. It's very important that all of us are prepared for the probably, hopefully not next pandemic. But if we are all trained in palliative care, we choose patients appropriately for ICU, we triage patients better, we handle ourselves better, we handle grief and loss better. It's very important that all of us know which patient should be selected to go on the ventilator, because we really don't have ventilators for 1.4 billion, right? In the ICU, again, a part of respiratory care, we should know when to not put patients on ventilator, when to withdraw patients from ventilator, how to have these difficult dialogues, and how to prepare, plan, advance medical directment, goals of care so that these patients are clear about what to do in an emergency. So with that, I really want to tell you that the needs of people at the end of life is similar. It is irrespective of the diagnosis. So we must remember that we live every day and we die only once. And we really need to focus on how we can treat that patient well with dignity and comfort so that he lives well and dies well. Because to be honest with you, this is something we're all going to experience. We don't have a choice of if we die, right? We have a choice of how and when we die, and that should be the right of every human being. So if I actually ask all of you, how have you all thought of your mortality and how would you like to die? What will be your answer?
Sudden death of acute MI, probably.
So you want to die peacefully, like wake up dead, right? Everybody. So if you ask a group full of human beings, not in the ICU, very honest answer. So how all of us want to die peacefully, want to die with respect and dignity. Why is it different for our patients? Because we never ask them. We never ask them their choice. We think it should be like a conveyor belt. Patient has come to casualty, patient goes to ICU, patient goes to the venti, patient goes to dialysis, patient goes in the coffin. We never stop and ask, how would you like to be treated? What are the principles of medical ethics? The four principles of medical ethics?
Autonomy, justice, non-maleficence, and beneficence.
Excellent. Autonomy means what? Asking the patient what he wants. Choice.
Choice.
For the patient to make a choice, he needs to know information. Where is he going to get the information if doctors don't tell him? The Google Baba will tell him. And when Google Baba A4 sheet comes to the doctor's consulting, the doctor is irritated. So you might as well select those few patients who are going to be asking you questions and give them upfront. What is do no harm? In a patient, stage 4 cancer, metastasis everywhere, is there any point in admitting in ICU, putting on the venti, giving ionotropes? Dementia patient comes with aspiration pneumonia. The patient doesn't even know his name or whether he's coming or going, but the 90-year-old will go on the ventilator because he can afford it. Should not be the reason to go on the ventilator, right? Tomorrow, it's going to be our turn. How would we like to be treated? We need to treat patients in that same manner, right? With dignity and respect. And that can happen only if we plan. That can happen only if we talk to people. And we really need to do no harm. Justice actually comes in the time of a pandemic. A 40-year-old with COVID and a 90-year-old with COVID. The world told us that the 90-year-olds don't do well with, so we should have actually kept these 90-year-olds at home and treated the 40-year-olds so that they could have returned back to society. But there was complete mayhem. There was no triaging. There was no concept of selecting patients appropriately to the ICU, withdrawing, withholding. We kept going, kept trying. For example, Lata Mangeshkar died of COVID. She was in ICU for 28 days and she was intubated twice. At 92, she was intubated twice. The reason she was Bharat Ratna was the singing, and we gashed it twice. For what? Eventually, she died a horrible death after having lived in ICU for four weeks. So we really need to sit back and think, why have we become doctors? To mitigate suffering or to be the cause of suffering for our patients and caregivers? Honest conversations, timely conversations, and if you don't know, you say, I really don't know how long this will go on for, but I do not see improvement. So let's see what you want to tell us. If you're not going to improve from your COPD, dementia we know is a one-way road, then what are we doing this? So anything reversible, we should fight tooth and nail. UTI, fracture arm, something, bed sore, everything we should fight. But anything irreversible, patient is in a coma, patient has got terrible blood gas, BP is in the boots. There's no point increasing the blood pressure to just keep the person alive. So we really need to choose as to why we have become doctors. It's not that palliative care is only for patients with cancer who are dying, it's for everybody. There's a lot of suffering across the patient and the caregivers. So we really need to focus on that. I'm now going to stop for a bit, but I want to, it's already 4:15. So where is Pallium? Should I do delirium or what should we do? I'm sorry, I overshot the respiratory palliative. Should we have a small discussion of what I spoke now or just rush into delirium?
So we don't have any other session scheduled for delirium for this
Yeah, I
time.
know, but can we, if they have the permission to, because again, delirium might not get over in 14 minutes. Maybe you need to revise your timetable about this, Pallium, because I have always struggled to do delirium and respiratory, because respiratory itself is quite robust. So, should we do a short discussion on respiratory and at the end of your session, maybe have half an hour for delirium? I'm happy to do that.
Okay, ma'am, we can do like that.
Yeah. So anybody has any questions, because we might as well do respiratory palliative care clearly, and any questions, any doubts, any thoughts?
And one doubt, usually we don't recommend benzodiazepines in COPD for management for insomnia.
So it's not for insomnia, it's more for anxiety. When we should use benzodiazepines in COPD is more for anxiety. When you have realized there's anxiety, when there is counselor who's dealing with the patients, only then you use, and you can use it in combination with the opioids, because sometimes just being extra breathless makes them more anxious and more breathless. So that vicious cycle you can. So it's not a sedative.
Oh, thank you.
Side effect can be sedation, but the doses we use is not for putting them to sleep.
Madam, for a stubborn cough, levocloperazine, is it useful?
So for refractory cough, again, it depends. Like I said, what is the cause? You need to be very clear whether it's gastric or it is due to some chest problem or a cardiac problem. Once you evaluate it and still you don't find any reason, you can start with codeine. But the problem with codeine is that not all cities have codeine available easily. In which case, you can then start with something like, say, the gabapentin low dose if it's really hassling the patient. And if it's interstitial lung, you can do morphine. Any more questions? So all of you work in hospitals or private setup?
Yeah, hospital.
Hospital. So I'm sure there are lots of places where you all can think about the futility of escalating care in certain patients. Okay, government medical college. Yeah. So it's very, very important to also, because we are a resource crunch country, especially the government. So instead of, we do not have resources for providing advanced care for everybody, and actually not everybody requires advanced care. Sometimes the diseases are so advanced that really we need to keep them only comfortable, and that we should know when to wear a palliative care hat and when to not wear a palliative care hat, and do as much as we can for that patient, even if there is a chance for survival. But the point is, when we think of patients, we only think of survival and never quality of life. It's always quantity of life. But what is the point if the patient is alive but not living well? Is a question that we should all ask, especially in the lower socioeconomic, where the toilet might be outside. There might be a small room with 5 or 6 or 8 people. There is no privacy, and these patients are out of breath. They cannot even walk to the toilet. So there's so many things we really need to understand and discomfort that a patient with advanced respiratory disease should have. So we really need to tailor make our treatment depending on where the patient is coming from. Anybody else that wants to share anything or any thoughts?
Ma'am, would you recommend some book for counseling on palliative care or some articles?
Counseling, you mean on conversations and communications?
Communication.
I can share some articles with Pallium. They will send it to the group. It'll definitely help. Some starting points. I'm sure you've had a session on communications.
Yes, ma'am.
You had. So the spikes protocol and all that has
Yes.
been discussed. But I will send you some articles just to, especially because these communications can be very difficult. Sometimes you can get stuck. I can send you some articles to read through Pallium. That is not a problem.
Sure.
I
Thank you,
think
ma'am.
that is very, very important. to be a good communicator, and it's easily, you can practice to become a good communicator. Anybody else? Okay. No more questions. I'll hand it back to you, Thank you. Thank you, Dr. Anil Kapoor. I think you are the one who was the most interactive. Thank you so much. Over to you.
Thank you for taking through the sessions. Thank you. So, we'll discuss with ma'am and schedule the delirium topic.
Yeah, because delirium is also an important topic to recognize and treat. And it's not everybody can get quite spooked about how to diagnose and treat. It won't get over in 15 minutes. So I'm happy to take a half an hour, 40-minute session.
Thank you. Thank you so much, ma'am. Thank you all the participants for being so much active, and thank you. Let's see in the next session. Bye.
So, sir, when we'll have this session on this delirium?
We will schedule and let you know in the WhatsApp group, sir.
Okay, because I think that is important. We have seen people going into delirium in the near of the end, and it's difficult to manage them, and especially the relatives, they feel a little disturbed
First
because
important part about delirium is to recognize it's delirium.
yes,
Second thing is how to treat, and then third thing is how to manage the caregivers, because they really get very, very upset with the
disturbed.
way the patient behaves. So it's very, and also the fourth thing is to recognize it's terminal delirium, that the patient might just not survive after that episode. So it's very, very important for us to take delirium. So we'll do another half 45 minutes. I've always found that I struggle with time when I get two topics like this, because there's so much to talk about respiratory palliative. Okay, so thank you very much to all of you for making it nice and interactive. And if there's anything, I'm leaving my email. You all are more than welcome to write to me. I can send you articles, or if there's a patient who is difficult, we can always discuss together and see what we can arrive at. Okay.
Thank you, ma'am. Thank you.
Thank you. Bye-bye.
Thank you, ma'am. Thank you, everyone.
Thank you,
Thank you,
ma'am.
sir.